Assalamu alaikum. My name is Noha and I am one of the pediatric neurology team in Mansoura University Children's Hospital. This lecture today is about childhood epilepsies, and this is one of the most common disorder in neurology, whether in children or in adults. It's going to be unfair to say that this topic could be covered in one lecture. So what we are going to try to do today is to give you a glimpse of childhood epilepsy, know how to diagnose it and what are the different types, and just a general idea about the management. So this lecture is going to go through these topics: the definition of seizures versus epilepsy, types of epilepsy, diagnosis of epilepsy, differential diagnosis of epilepsy, and then finally the management. So starting at the beginning with the definition of seizure versus epilepsy. What's going to happen in the next few slides is that I'm going to give you the exact definition as you may see it in papers or in textbook, but at the same time we will try to apply that to real life and practical life. Through the whole presentation we will take a case and we are going to apply every part of the presentation into this case. So when we look at the definition of seizure, a seizure is any sudden event that seizes the patient activity. Simply that means that whatever you are going to do, if you have a seizure, it's going to stop your activity. So if you are standing and walking, you are going to stop walking. If you are sitting, you're going to stop sitting. If you are talking, you stop talking. Alright, so it is an event that seizes your activity. Any seizure can be caused by a disturbance in the brain neuronal activity. This is what's called epileptic seizure. Or it may be caused by a lot of other mechanisms. So for example, you can have low blood sugar and that will cause you a seizure. You can have a high blood pressure, low blood pressure, and that can again cause you a seizure. The main difference is that if the reason for the seizure is abnormal neuronal activity, this is called epileptic seizure. If it is any other reason, then this is just simply called seizures. And as you may imagine, in life there will be a lot of seizures, a lot of causes. So any one person in life, there is a 50 to 50% chance that he may have a seizure. Someone may have a heat stroke and then have a seizure. Someone may have dehydration, so low blood sodium or blood sugar, and then have a seizure. If someone have a seizure and it is not an epileptic seizure, then again this is not epilepsy. This is not going to be recurrent. Once you correct the cause for the seizure, then the seizure is not going to happen again. Then again this is not epilepsy anymore. So I just wanted this to be clear. Seizure is just a symptom of an abnormality that can seize your activity. The cause may be different, and that's why it's very important to always look for the cause. Now, going to an example for that is a 12-month-old boy who suddenly has a very high temperature, 39 degrees. His body will start reacting by having the convulsion or a seizure. Once the temperature stops, the seizure will stop. This seizure is because it seized his activity, so we called what happened to him a seizure because it seized his activity. But at the same time, this is not epilepsy, it is just simply a seizure. It will go away, you treat the cause, and that's it. Okay? Now, we will see what is the difference between a seizure and epileptic seizure. An epileptic seizure is a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. When we say synchronous, we mean gather together or working together. So both hemispheres of your brain having neuronal activity that are working together. So the epileptic seizure, its origin is coming from the brain. You look for blood sugar, it is normal. You look for blood pressure, it is normal. You look for metabolites, it is normal. So every possible cause is excluded, and then the only reason you're having the seizure is that brain is creating a seizure. And that's why we sometimes say that epilepsy itself is the ability of the brain to generate epileptic seizures. So your brain generates seizures without any reason at all. In order for a patient to turn from epileptic seizures to epilepsy, the patient needs to have recurrent epileptic seizures, so at least 2 seizures in more than 24 hours apart. So if you have a seizure today at 3 p.m. and then another seizure today at 6 p.m., that is not epilepsy and that is not recurrent. Both of them will be considered as one seizure. But if you have a seizure at 3 p.m. today and then 3 p.m. tomorrow, then again this is a recurrent seizures. And the seizure need to be unprovoked. Unprovoked means there is no other reason for it. You look for blood sugar, blood pressure, blood metabolites, any trauma, nothing at all. So at the end of the day, this brain is able to generate seizure on its own. That's what's called epilepsy. I hope now you start having a flavor of the difference between seizures and epilepsy. Okay, so let's see this example. Amina is 13 years old. She has type 1 diabetes mellitus. Since the age of 8 years old, she is currently not well controlled, and she was admitted to the emergency department with the following story. She was asleep. Mom heard noises. Amina was lying in the bed, eyes open, drooling, whole body was shaking. She was not responsive for 3 minutes. Mom measured her blood sugar, and the blood sugar was very low. It was 1.5. So she gave her sugar. Amina started to wake up and stop the shaking and start to become better. Now, what was this? It was a seizure. Why it was a seizure? Because it stopped her activity. She was sleeping and she is not sleeping anymore. She wake up because of that. Okay, and the description looks like a seizure. What was the cause of the seizure here? It was the low blood sugar. So is this brain going to be able to generate seizures without low blood sugar? Till now, no. The main reason for having the seizure was the low blood sugar. So is it epileptic? No, it's not epileptic. Why? Because it was provoked by hypoglycemia. Okay, so this is the first part of our story here. In order to be able just to understand what I was trying to say, can you tell me which sentence is true? All epileptic seizures are seizures, or all seizures are epileptic. You have 5 seconds. 1, 2, 3, 4, 5. Well, definitely it is the first one, because all the epileptic seizures are seizures, but not all seizures are epileptic. Okay. Please ignore this slide. Don't look to it. Now, into the second part of the lecture. It is the types of epilepsy. Okay. Types of epilepsy depends on the type of the seizures. So types of epilepsy depends on the type of seizure, and we have 2 main types of seizure, which are generalized and focal seizures. Let's try to understand what's the difference. Okay, so for the generalized seizures, it is expected that the neuronal disturbance will affect both hemispheres, will affect both sides of the brain. While in focal seizure, it is expected that the neuronal disturbance, whether it is hyperactivity or synchronous activity, will affect only one hemisphere, one part even of the hemisphere. Okay? So it is a little bit like this description or this picture, and it shows, well, the seizure starts in one point, yes, but it spread to every part of the brain and almost equally. And so if you have any device that can record the electricity coming out of the brain or the neuronal activities coming out of the brain, you will see that it is affecting all the brain at the same time, and that's what is called generalized seizure. When that is happening, it can manifest on the patient in different forms, and we will know that later. But for the focal seizure, the activity will start in one area of the brain, but it does not spread to the whole brain. No, it just spread to one area only of the brain. So if you again have a device to record the electricity or the disturbance of the brain, you will find that this affects only part of this brain activity, not all of it. Okay. Now, both generalized and focal seizures, they present in different forms. So for generalized seizures, they can present either in tonic seizures, clonic seizure, tonic-clonic, myoclonic, absence, or spasm. For focal seizures, they can present as tonic or clonic or tonic-clonic. This is not an exhausting list of all the types of seizures. There are other types of seizures that I have not put into this list because I think it will be a little bit advanced. But for now, these are the types of seizures that I feel it's important for you to realize. What's going to happen now is that we are going to see some videos of different forms of seizure, so that you can have a flavor when we say generalized clonic seizure or generalized tonic seizure. What does this mean? Okay. So these are the videos. So what's going to happen now is that I'm going to show you the video, and then I will start commenting on it. Okay. This is just simply a generalized clonic seizure. So please look to what's going on.
Oh, I'm sorry, Bella.
So what happened is that all the different parts of the body are acting.
Right in the heart, dude.
You can see that it is only localized to the arm or the leg. No, it is both arms, both legs, even the eyes and the mouth.
Alright.
Okay.
It's done.
I will turn that from the beginning again.
Oh, I'm sorry,
You can
Bella.
see that the eyes are
Alright, baby.
open. Okay. And this is one of the very important features of any true epileptic seizure, that usually the eyes are open. Okay. And then
Right in the heart,
you
dude.
can see that the child now is getting off the seizure, and so the jerking start to decrease and then stop.
Alright.
And when it stops,
Done.
the child looks like he's exhausted and gone to sleep. This is when
Poor
the
heart's
brain
going
rests,
so
and this is what we call post-exercise.
I want you to do that.
So if I want to describe
The doctor
exactly
said
what's
that.
going on here,
Nope.
I would say that
No, she's not seizing again yet.
I'm sorry,
this
Bella.
child was having
Alright, baby.
generalized jerking, which was rhythmic jerking, affecting
Right in the heart,
eyes,
dude.
mouth,
I know.
arms, and legs. This is what's called clonic seizure. So clonic seizure means jerking, and it is rhythmic jerking. It's not just any jerking, it's rhythmic, it's coordinated. It's most probably either generalized or focal. Okay? So this is how a generalized clonic seizure looks like. Now we are going to look into this next video. This is a generalized tonic seizure. I just want you to understand exactly what is the meaning of the word tonic. Tonic means a sustained contractions of group of muscles. Okay? Look to the video and then you will start understanding what I'm saying. So this is a boy who have some form of learning disability. He's talking, but his words are really slow. He's eating and he feels that he's not properly reacting. Okay. I'll just make that a little bit forward.
Last time I was at school, I had water going on my nose.
Still look into the video. Okay.
Something really funny?
You can see what happened. We have a generalized contractions of group of muscles affecting his neck, his arms, and his trunk. Right? So this is a generalized tonic seizures. Now, few things I would like you to notice beside the word tonic here. First of all, when this seizure started, it started actually
I was at
quite
school.
sudden. So he was talking
Something really
and then
funny?
suddenly as you see that happen. This is one of the main differences between true epileptic seizure and any type of seizure. So say for example, I will just stop the video here. Say for example, you have a hypoglycemic seizure like our case Amina. Usually, if it is not a true epileptic seizure, you will have some warning. She may have some palpitation, some sweating. She may be able to kind of sit if she was standing. So usually there are some warning signs. In true epileptic seizure, you do not have any warning signs. What's going to happen is going to happen immediately and suddenly. Like this boy, he was sitting, he was eating and talking, and suddenly he started having the seizure. Now, this seizure is now fading, and you find that the boy does not get back to himself for a while. It will take a time, and that's again one of the criteria for epileptic seizure, they do not end immediately.
You okay?
They will take time until they go away. So now you understand what's meant by generalized tonic seizures. Okay. Then you have myoclonic seizure. Again, before you see the video, the word myoclonic means sudden contraction. There is a difference between tonic and myoclonic. Tonic means sustained, persistent contraction, but myoclonic means sudden contraction of a group of muscle. So look exactly what's going on here. This is a boy sitting. Okay, he looks around himself. Yes, and then his head dropped. Right, this is because there is a contraction in the group of muscle of the neck and the trunk, and then another one. Okay, and then another one. This is going to continue for the next, for example, 2 or 3 minutes. This is called myoclonic seizure. Myoclonic seizures usually happen in clusters, which means that they can happen like 3 or 4 in succession. Okay, usually they are not a nice type of seizure, and usually they are accompanied by other seizures. So for example, this boy, the same boy, may have the myoclonic seizure and may have generalized tonic-clonic seizure as well. Okay, right. Till now we have talked about types of seizures which represent the type of epilepsy. We know that there are generalized and focal, and then from the generalized type we know that generalized tonic, clonic, myoclonic and absence. Now if we start looking into the focal seizures, like we have explained before, they will arise in one part of the brain, but they are not going to spread to the other parts of the brain. Alright, so if they arise only in the frontal lobe, most expectingly they will represent only the frontal lobe. They will not have manifestation of the parietal or occipital or temporal lobe. This means that the seizures coming from the frontal lobe will have the same function as the frontal lobe. And that makes me ask you, what are the functions of the frontal, parietal, occipital and temporal lobe? You have what? 10 seconds and you can try to write what is the main function of the frontal lobe. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Good. You didn't write anything, I know that. Okay. So usually frontal things or frontal lobe will have motor functions and higher intellectual function. What we mean with that, that most of the seizures coming from the frontal lobe will have motor manifestation. It could be clonic, it could be tonic, it could be anything. It just has some motor function into it. Parietal lobe will come with abnormal sensation. As a patient will suddenly feel that something is wrong with his tummy, there is some pain, some abnormal sensation. This is parietal lobe. Vision coming from the occipital lobe. Temporal lobe, emotion, hearing, smell. So if there is a focal origin of the seizure in the temporal lobe, the patient will come with presentation representing the function of this lobe. So it will come either with a problem in smell or hearing or emotion. Okay, let's look into this video of a girl who does have focal seizures. It is focal clonic seizures. I just want to give you some kind of flavor. So it represents some form of what? Of the frontal lobe. Okay. Now you see that into this right eye. You see how it is flickering here and jerking. It is the right eye only. Okay. But if you have a good eyesight, you will notice as well that the left hand or the left arm is into atonic posture. Okay, so these girls have focal seizures in the form of right jerking of the right eye, and she has left hand tonic depression as well. Okay, it's called multifocal, but you don't have to. So this is how a focal seizure looks. I will just start from the eye so you can remember. Now you can imagine that can happen on the right arm or the left leg or so. Now if you have a seizure into the right eye, what you are expecting is that the problem will be in the left side of the brain. So the left frontal lobe of the brain is causing motor seizure on the right side of the eye. Okay. Good. So she was a patient who was 8 years old. She did have some seizures at the beginning, but when they looked into it, they found that all these seizures were hypoglycemic. So she did have hypoglycemic seizure. She was 8 years in the previous slide, but in this slide she is now 18 years. She has been uncontrolled for a long time, and she has had lots of hypoglycemic seizure, and then she started developing the following attacks. So what is the form of these attacks? She suddenly stops what she's doing, drops, starts shaking all four limbs rhythmically, eye open, not responsive. That will continue for 2 to 3 minutes, but she cannot be back to herself except after another few minutes, and then she may go back to sleep or to what she's doing. The frequency of these attacks is about 2 to 3 per week, any time of the day. Now, what do you want to ask? What do you want to know? I personally, the first thing I would like to ask is that, since she's still diabetic, if she's having hypoglycemia. Well, no, she's not having hypoglycemia. So what it is a seizure because it ceased her activity. Is it provoked? It was not provoked because there was no hypoglycemia. They tried some different tests and she didn't show any reason for that. Was it recurrent? Yes, it was recurrent. Okay. What type of seizure do you think that this is? I mean, sudden fall to the ground, shaking rhythmically, 2 to 3 minutes, eyes open. Do you think that's clonic, tonic, myoclonic, absence, or focal? I think the best thing to try and look to it is that either to respond generalized or focal, and then determine if it is generalized, which type. So according to mom's description or the family description, it's affecting all of her body, so most probably will say it is generalized. Now the second thing, well, if it is generalized, is it clonic, tonic, or myoclonic, or absence? So generalized rhythmic jerking all over the body, it is clonic seizure. Okay. Could it be epileptic seizure? It is possible, but we need more information in order to be saying that. That's when we come to the third part of this lecture, which is about the diagnosis of epilepsy. Okay. Now, the diagnosis of epilepsy is mainly a clinical diagnosis. Okay. This means you have to take a very, very good history. You have to have a good knowledge of the different types of seizure, and then you have to have good knowledge of the other common disorders that may look like seizures, but they are not, of course, seizures. Alright? Again, there is no magic tool or investigation to diagnose epilepsy. It is a clinical diagnosis. That's why it is very important to take a very good history, to ask the parents to video the attacks and take a look at the videos, because I'm 100% sure that when I was talking to you about the different types of seizure and I start saying generalized, tonic, and clonic, that didn't mean anything. But once you started looking to the videos, you started understanding what a clonic mean, what a tonic mean, what a myoclonic mean. And even if you didn't know what is the type of seizure, but you definitely know from the videos that something wrong is going on here. Okay, this was not just simply a kind of a movement or a syncope or something else. That was something serious that was going on. So two main things come out of this lecture. One is important to take a very good history. Second is always to ask for videos. When you are trying to take a history, there are a few things that you need to know. Most of the family will come to tell you about the seizure. They will start, like for example with Amina, they will start saying that she was shaking all of her body, eyes were open, she was wetting herself, stuff. But usually they will forget about the event that was before the seizure and the event that were after the seizure. And honestly, these are very important because they can tell you if these are seizures, epileptic seizure or not. Okay, so in the following slide, these are some tips of the important questions, okay, that you need to ask the patients. So for example, when you start asking the patient about the seizure, start asking if it was from awake or sleep, what time was it, what the patient was doing, standing, sitting, crying, fighting, Was there any precipitant, fever, trauma, or anything like that? Here are some tips. First of all, epileptic seizure never follow a time or place or person. What does this mean? If a father comes and tells you that my son had a seizure every night at 11 p.m. every night, definitely this is not a seizure. Okay, there is nothing called that a seizure comes every night at the same time. But for example, if the same father tells you that my son always have a seizure while he's going to sleep, regardless if he's going to sleep at 8 p.m. or at 11 p.m., that may be a seizure, because usually seizure becomes more predominantly easier if it happens during the going into sleep or coming out of sleep. So epileptic seizure, true epileptic seizure, never follows the same pattern. Okay, so can't be constrained to a certain time, it can be constrained to a specific place. Again, if someone tells you that my son or my daughter has a seizure every time we go outside of the house, that's not an epileptic seizure. Okay, if she meets her grandmother, she starts having a fit, definitely she simply doesn't like her grandmother. It does not have anything to do with epilepsy. Okay, remember that part of the definition of epilepsy is to exclude precipitants, and that's why you need to ask about the fever, the trauma, any metabolic disorder, any known disorder. Like for example, our case of Amina, and she is diabetic. If she starts having seizures, the first thing you would think about is hypoglycemia, hyperglycemia, hyponatremia, blood pressure, and so on. And then if you exclude everything in the world, then you may start thinking about epileptic seizure. Okay, so it's very important to realize what are the causes below seizure. Then, when you start asking the patient or the parent about the seizure, first of all, let the parent explain and tell you about what has happened. Sometimes you may try to limit the time, because they are going to express how fearful they were and how they cried and how they tried to call the police and the neighbors and stuff like that. Well, you can listen for a minute or two, and then you stop them, and then you ask them about a video, and if there is no video, you ask them to have a video for the next time, and then you start asking the following question. You start asking about which side of the body, was it generalized, was it focal, did it affect all four limbs or just one limb, was there any eyes open, because remember, having the eyes open is one of the main criteria for having an epileptic seizure. Even if the patient is asleep, they will wake up, have their eyes open, have a seizure, and then they go back to sleep. So always remember to ask about the eyes. Ask about drooling, ask about head turning, for example, if the patient was responsive or not. Okay, and then ask about what happened after the seizure. Did the patient remain unresponsive for a while, like you have seen in the videos, whether for the tonic or clonic seizures? Even after the seizure is finished, the patient does not come immediately to himself or herself. They will take a time. This brain was on fire, so it will take some time until the brain rests and then start working up again. So if someone tells you, well, my child have a seizure, once he has a seizure, he stands up and then walk out to the garden and play, well, you have to be suspicious about that. Okay? Sometimes if you have a focal seizure, sometimes it may leave one of the limbs to be paralyzed for a while, which is called Todd's paralysis. But anyway, we don't have to worry about that. It's just simply to ask if there is any remnant weakness in one side of the body or anything like that. You need to ask about other important things, because if the brain is generating seizures, this is the brain that is important for development. So you need to know about the development of the child, and if the child was normally developing before that or not. You need to know about if there is any other abnormal neurological symptoms or signs, like for example, is this child having headache, is this child limping, for example, if this child was a hydrocephalus or anything. Of course, prematurity and perinatal history will be very important. Behaviors, and of course if there are any other systemic conditions. Okay, please do not forget to ask about development. When we treat epilepsy in children, our main aim is to avoid any things that affect their development. So it's really very important to know what their development was, so that we know how the seizures or the epilepsy is affecting them. So again, coming back to the diagnosis of epilepsy is mainly clinical. Okay, so you have taken the history. Now you need to have knowledge of the different types of seizure. So in the last part we have talked about the different types of the seizure. When the parents are talking to you and you are asking them about the seizure and what happened, usually you are trying to fit the scenario into one of the seizure types that we have talked about before. So for example, if they are saying, if the patient is having a seizure, you have to stop them and ask, what do you mean by a seizure? Then they start saying they were shaking. Then you start asking, is it rhythmic shaking, or the hands was in one place and the leg was in another place? So you start saying, no, it was something like a rhythmic shaking. They may even try to imitate it on themselves. Okay, and then you try to think, well, we have seen that in one of the videos before, that looks like clonic seizures. Okay, or for example, the parent will say, well, he was numb, his body was completely numb and stiff. Well, stiff, that usually fit with tonic seizure. Or the parent will say, well, he's having seizure where he drops, or he suddenly have his head nodding. Okay, that looks like myoclonic seizure. So whenever you're taking the history, trying to incorporate this history into one of the types of the seizure, you know. Now, if you cannot find that the history is fitting into one of the types of the seizures, then this is not epilepsy, this is not epileptic seizure. Okay. Then comes the third part, which is good knowledge of the common non-epileptic events which look like epileptic seizure but are not. Simply, it's just doing some kind of a differential diagnosis, really. So you have taken the history and then you have put into your mind, well, that looks like generalized or focal seizure, and then you need to know, well, could this be something else? And really that takes us to the fourth part of the lecture, into the differential diagnosis of epilepsy. There are different things that look like epileptic seizures, okay? And again, this only just an elaboration. It's not an exhaustive list of different disorders that looks like seizure. But movement disorder, sleep disorder, psychogenic, syncope, cardiac causes, febrile seizure, breath holding, etc., all of that can look like seizures. To differentiate between disorders and epileptic seizure, you need to know what disorders look like and you need to know what seizures look like. But I will give you some. Look for this child, for example. What's going on here? He's crying, okay? And you can see that his mom is there. It's just not really freaking out with what happened. And then after he was crying, you can see that his lips here are becoming a little bit blue. He may have some jerking, but it is not a rhythmic jerking. But then he closes his eyes and then he looks like if he has died. Actually, he is not. He's actually starting to breathe again. And what happened next is that he will open his eyes and wake up. Go back immediately to what he was doing before, which is so this is what's called breath holding attack. Okay, these breath holding attacks simply happen in all children, not all children, but most of the children between the age of 6 months till the age of 6 years. Usually they will settle down by the age of 2 years. What happens is that these children cry, and crying is expiration, so they are not allowing themselves to have any air getting into their brain. So their brain is just like trying to give them a kind of a pause so that they can breathe normally again. And this is when they look like they have died, but actually they haven't. So look to the video again. He was crying, so that was all expiration. He's not taking any inspiration. Right. So his brain needs to save him from himself. So what he's doing is that the brain kind of stop him Okay,
What's going on? Are you okay?
he stopped crying so that he actually stopped
Well, these
breathing.
bees getting you.
Once
Do you
it's
know you were
breathing,
in a fake
the
hug?
bees can
Fake
start
love?
waking up and concerned.
You had no
So
choice.
this is called breathing.
You're queen?
Can you differentiate between this and between a seizure? First of all, it looks like a seizure. Yeah, I can argue that. But there are some few things that you can make sure that does not confuse you with seizure. First of all, remember when we said that epileptic seizure happens suddenly? Well, this is here not happening suddenly. You know, you can see that he has been crying, turning, falling to the ground, losing consciousness. So it is gradual, okay? And then at the end, what happened? Usually we said that with epileptic seizure, usually after they finish, the brain needs some time to relax. But see here, once he is waking up, he goes back into crying again. So the onset is usually gradual and the offset is usually sudden. Okay, that can give you a little bit of a flavor between the difference between them and between epileptic seizure. Usually, it's not just usually, it must happen every time with crying between the age of 6 months to the age of 5 years. Most probably will disappear by the age of 2 years, sometimes maybe related to iron deficiency. Okay, let's look at Doozy's girl, what she's doing. Most probably
Allowance. What are you going to do with your money from next allowance?
Now look into her
Maybe
eyes,
I'll
okay?
get another hard book.
Oh, that's a good idea. Do you know what you're going to get
Do you
yet?
see this movement
Maybe
of the
that
eyes?
Guardians of Gagu.
Okay.
Oh.
Maybe
The
if the
three-pack?
parent is
Oh.
describing that to you, he would say,
At first I have
that
to read
looks like
Kate,
deviation,
and
sudden
then I can
deviation
read
of
the
her
first
eyeball.
one, the
That's
second
right.
Gagu,
Yeah.
and the third.
Sounds like it's
And if-
exactly.
I read
What is the
those
main
all.
thing that differentiates this
We
from
get to put
suicide?
all those posters up. Do you want one down here?
Twice now. Remember the very first definition of the seizure, what it was.
Allowance. What are you going to do with your money from next allowance?
Right. Did
Maybe
this
I'll
movement
get
here
another
seize her
hard
activity?
book.
Did it stop her? You can see her
Oh, that's a
talking.
good
She continues
idea.
talking.
Do you know what you're going to get
Didn't
yet?
seize her activity,
Maybe
didn't
that
do
Guardians
anything.
of
So this is not
Gagu.
a seizure.
Oh.
The
It's just
3-pack.
simply a movement disorder. It's a form of text.
At first I have to read Kate, and then I can
This
read
is,
the first
again,
one, the
that's
second
one of the things that
Gagu,
can
and the
easily
third.
be mistaken
And if-
for a seizure, but if you can see
I
the
read
video and
those
you know
all.
the difference between
We
different
get to
epileptic
put
seizure
all
and
those
movement
posters up.
disorder, and you go back to the basic definition, which is what a seizure, seizure
Do you want one down
activity,
here?
you
We
realize
can
this
have
is
the
not a
wolf
seizure.
one. Have that one, okay?
So this is text. Let's look into this lovely boy, what he's doing. Doesn't seem like this video is going to be working, so I'm not going to comment on this one. Okay, we will just move. It was a movement disorder as well, so you don't have to worry about it. Then we have another important type of seizure that usually mistaken for epilepsy, which is called febrile seizure. So these seizures that happen in child between the age of 6 months to the age of 6 years, usually in the setting of an acute febrile illness and without any previous afebrile seizure, no neurological abnormality, no CNS infection. Febrile seizure looks exactly like epileptic seizure, but usually, not usually, every time you will have a temperature, it could be from 38 till 40. There is no evidence of CNS infections, there is no evidence of neurological abnormality. Okay, so what I mean by neurological abnormality, that say for example you have a 2-year-old boy who is having a high-grade fever which is 39 degrees and he start having a seizure. That looks like a febrile seizure, but if this mom say, well, this boy was a preterm and he had a shunt and he usually have paralysis in his left side of the body, but now he is having seizure because of the fever. No, this is not febrile seizure. Why? Because simply he was having an abnormal neurological examination. He does have weakness on his left side. Okay, that's mean by no significant neurological abnormality. So differential diagnosis of epilepsy, like we said, a lot of cases, a lot of different things. Always look for the basics. Did that attack seize the patient activity? Then it is seizures, and what type of seizure, and then you start differentiating it from the common things. in pediatric, breast holding attacks, febrile seizure, movement disorder are the most common things. If we go back to our case, Amina, who is 18 years old and she started having these attacks, this is the same slide as before. Now, you took the very good history, alright, and watched the videos of the attacks, and you discovered, well, the attacks were not provoked, okay, the attacks were recurrent, the attacks looked like generalized clonic seizure, the attacks didn't look like movement disorder or sleep or cardiac, and she's 18 years old, so she's definitely not having breast holding attack. So it is possible that Amina is having epilepsy, yes. So although she was having hypoglycemic seizure before, but now it seems like her brain on its own is generating seizure without the need of hypoglycemia. Alright, this is now called epilepsy. Alright, so how you are going to manage Amina? This will take you to the last part of that lecture, which is the management of epilepsy. Management, as in any disorder, include investigations and treatment. Alright, and for investigation, you have to remember one main thing: the diagnosis of epilepsy is clinical. There is no magic tool to diagnose epilepsy, and the diagnosis is clinical. Again, it is clinical. So, why we do investigation? We do investigation just to exclude other important causes and to define the type of seizure. So, exclude other important causes like abnormal heartbeats, so that's why you need to do ECG, abnormal blood sugar, that's why you need to do a random blood sugar, take the blood pressure, and you may do a brain imaging. Now, I'm sure that in this pediatric course you have taken some APLS, acute pediatric life support, you have taken some scenarios in acute measures, and if you remember, the first thing you do when you have a patient who is having a seizure is to measure the blood sugar. Alright, now the second thing that you are going to learn today is that when the patient finishes the seizure, you need to do this patient an ECG as well. Yes, ECG on the heart. You are going to look into the heart. Why? Because there are a lot of abnormalities that may manifest as seizure, but actually they are due to cardiac abnormalities, and I'm talking about cardiac rhythmical abnormalities, like for example heartbeat drops or conduction problem, long QT syndrome, and stuff like that. So it is very important before you diagnose a patient with epilepsy, you have to exclude serious things. You have to exclude hypoglycemia. You have to exclude cardiac reasons, and that's why nowadays the first thing you do for a patient is to do him an ECG, not an EEG, an ECG. Okay. And then you may do a brain imaging depending on whether you feel this is necessary or not. Then, to define the type of the seizure, you would do the EEG. I'm not intending to put the EEG in details here because, like we said before, diagnosis of epilepsy is clinical, and that's what I want you to take from this lecture. But just to simply explain, EEG is electroencephalogram, which means that we are recording the brain activity by electrodes that are put into the skull. They are distributed all over the skull so that we can measure from the different loops of the brain. The electroencephalogram gives you an idea if the brain activity is abnormal or normal. In order to define the seizure, you need the patient to have the seizure on the EEG, which of course is not usually accessible. And that's why it is not very good to depend only on the EEG for the diagnosis. It's better to have a good video than actually to have a good EEG. Okay, but when you say, for example, you have seen the video for Amina and you see that she's having a generalized tonic-clonic seizure, okay, but you want to make sure that actually these are epileptic seizure or not, or you want to define if these are generalized clonic seizure or not, you are going to do an EEG that's acceptable. Okay, not to confuse you, investigations have two main goals: exclude important causes like cardiac causes like blood sugar, blood pressure, and to define the type of seizure, which is generalized or focal, by doing the EEG. Okay, and the third reason you would do an investigation really would be to look for the cause. I'm sorry, this is not written here. So looking for the cause, that can be done by doing imaging, either CT brain or MRI brain. Okay. Now management, that includes treatment, and the main aim of the treatment here in epilepsy is to decrease the risk of having epileptic seizures. So for example, someone is having epileptic seizure every 1 week or every day, so what you want to happen is that for him not to have an epileptic seizure. Why? Because he may have this seizure while he's walking, so he may drop and hurt himself. He may have it while he's crossing the road, so he may be hit by a bus. He may be having it when he's having a shower in the bus, and he may drown. So this is the main aim, really, is that to stop people from having seizures, and so avoid them the risk of the seizure itself. Again, one of the other cons is to avoid the significant adverse effect of seizures, and I will put the word development again here, because one of the main concerns we always have on the children who are having epileptic seizure is that their development will be affected, and that's why we try to stop the seizures, especially if they are very young. Okay. Generally speaking, you have what we call broad spectrum anti-epileptic. These are medications that are effective in generalized and focal seizures, and these include one of the very old medication like sodium valproate and lamotrigine. And then you have what's called narrow spectrum anti-epileptic, and they are effective only in focal seizures, and example of that is carbamazepine. Why it's important for you to know this classification? Because if you give narrow spectrum anti-epileptic like carbamazepine into generalized seizures or generalized epilepsy, what is going to happen is that you are going to increase the number of the seizure. So remember Haley, who was having absent seizures. Okay,
Doing a long video, honey.
these
I
are
can see you.
absent seizures, generalized.
Bless you, William.
Part of the seizure. And medication like carbamazepine, then what's happening is that Haley, instead of having 10 absent seizures in a day, she will start having 100 absent seizures in a day. Okay.
Haley, what's up?
The same thing happened for myoclonic seizures.
Haley, what's up?
The child was having like 50 myoclonic seizures in a day. He was
Haley,
what
are you doing?
If you give the carbamazepine, that's why it's very important. Generalized or focal, and then you know which medication you want to give, broad spectrum or narrow spectrum. If you don't know, it's better and safe to use the sodium valproate, but I would say it's better and safe to talk to someone who would know. Okay. The main rules for starting an anti-epileptic medication is usually to start with one medication. So for example, in the market here in Egypt, we have at least about 15 anti-epileptic medication. So if a child comes to you with 2 generalized tonic-clonic seizures and you feel that the parents can buy all the treatment in the world, you don't try 2 or 3 anti-epileptic medication. You start only with 1 anti-epileptic medication. You start with the lowest dose, and then you start increasing the dose slowly, okay, until you reach to a dose where it stops the seizure. That will be easy to define when you're having someone having seizures every day, for example. So if they start having no seizures in 3 consecutive days, that means that this dose is working. But sometimes it's quite difficult when someone is having a seizure every like 3 or 4 months, because in these 3 or 4 months you will reach a dose, you will leave the patient on that dose, and then you will wait. If they stop having the seizure at all, then this dose is working. If they start re-having the seizure, then you will need to increase the dose. Sometimes you increase the dose slowly, and then you get to the maximum dose you can give, but the seizures are still happening, and in this case you may need to add another medication. So please remember, we do not start with multiple anti-epileptic medication from the beginning. Okay, sorry for the interruption. So as we were saying, we do not start with multiple anti-epileptic medication from the beginning. We start with 1 and we increase the dose slowly. If we reach to the maximum dose and that does not work, then we add another one. Please remember, these anti-epileptic medications do come with side effects. They work on the brain, and we are giving them to children who are still developing. So it is really, really harmful to give unnecessary anti-epileptic medication to children. and you give unnecessary anti-epileptic medication to children when you diagnose them wrongfully. So for example, you have a patient who actually is just having seizures only when he is crying, and you diagnose this as seizure and you start anti-epileptic medication, while the true diagnosis is breath holding attack. So again, history will help you to give the right medication. Okay. What are we looking for? We're looking for 2 years free of seizure. If a patient remains 2 years free of seizures, then we can start considering taking the medication off, and we usually take that slowly. This is a general rule. We have a lot of exceptions right now because there are a lot of classification of epilepsy. If you have time and you decided to look into this lecture again, you will see that the name is childhood epilepsies, and that is a plural name, and that's because we have different types of epilepsies. Epilepsy is not just one disease with one type of seizure and that's it. So generally speaking, yes, we aim for 2 years free of seizure, but I will be very cautious because there are different types and we may need sometimes to remain on the anti-epileptic for a little bit longer. Okay, now going back to our case, and so from the case history you realize that she was having non-provoked seizure which were recurrent. You were thinking that these were epileptic seizure. How you are going to manage? First, you are going to make sure that they are not provoked, so you are going to take the blood pressure, the blood sugar, and because she's actually diabetic, then you would like to know the blood sugar between the attacks and during the attacks, and you will do an ECG. All of that come back normal. You have an EEG, electroencephalogram, that shows that she's having generalized seizures, and now you can make the diagnosis of epilepsy because you have made a differential diagnosis of everything else, and you find that this is only fits with generalized chronic seizure. And then you are not going to treat her because you are going to discuss her with someone who knows how to treat her. I really emphasize the idea that diagnosis of epilepsy is clinical and that requires experience, and we do appreciate that newly graduating doctors may not have this experience, and it's very important, if you really doubt clinical seizures that they are epileptic, please talk to someone who may have a little bit more experience than you, because if you diagnose that correctly, then you will need to start a medication correctly, and that will require some experience. If you diagnose that wrongfully and you diagnose something else as epilepsy, you are actually harming the patient. So please, if you doubt epileptic seizure, discuss that with someone else. Okay? So in conclusion, there are different types of seizure, provoked and unprovoked. Epilepsy is a disease, not just seizure. Epileptic seizure could be generalized or focal. Diagnosis of epilepsy is mainly clinical, and choosing the right anti-epileptic medication is crucial for you because it may worsen the seizures. I hope you enjoy this lecture. I would suggest that you listen to it one more time and then you hide the voice and start going through the lecture on your own without the voice at all, and I'm sure you will be able to understand it more. If you like to see more videos, there is what's called the Epilepsy Action website, and there is what's called the ILAE, the International League Against Epilepsy, and it has its learning website which has all the videos for the different types of seizures, and they are for free. All you need to do is to register with your email and your name. And of course you can go to YouTube and you can look into the different types of seizures, but they may be wrong. The only one thing I would like you to take out of this lecture is that diagnosis of epilepsy is clinical. Please do not depend on an EEG or not, and do not start medication unless you are 100% sure about your diagnosis. Thank you, and the very best of luck.